Welcome back to Habitual Excellence. I'm Mark Graban, and we're joined today by Dr. Tom Peterson. He's Vice President and Chief Safety Officer at Trinity Health in Michigan. Tom, how are you?
I'm great today. Thank you, Mark.
Thank you for joining us. And before we talk about safety and other things, maybe you can tell the listeners and viewers a little bit more about your background.
Sure. I'm a pediatrician by trade, so that's what I worked in for a number of years, and then I got into the safety quality world about 15 years ago, and started what we call the HRO work or safety work that a lot of people refer to about that same time. So I've been working in the safety and healthcare in multiple organizations for about 15 years. So this is the biggest one I've been in is Trinity Health. It's a huge system. But I've been in children's, adults, rural, academic, community, all kinds of hospitals. So seen them all.
Yeah. And we're going to talk today about safety. It's kind of a broad topic, but just want to hear some of your thoughts to get started around, why that's such an important topic for you personally, why that's such a meaningful topic in healthcare.
Well, it's a really passionate topic for me because I think what I've kind of come on in my career is I like to get involved where there's huge need for issues. Mm-hmm. I worked in tobacco control for probably about 30 years. There's issues of, I think when there's a really obvious gap, and it seems, that's where I think I just look at it as a part of my role to fill. So. And safety, as it's gone on and the time I've been in it, it has evolved, it's changed. There are different ways we did things 15 years ago than I would do them now. But it is an incredibly huge issue in healthcare. And not just hospitals, but in ambulatory care and senior centers. It's obviously a huge issue with the COVID-19 stuff now. But it's, and I've always watched the non-healthcare organizations, how well they've done it. And that's been kind of my drive all along, is to make it better and better in healthcare. So,
and we can delve into some details around some of these things that you've mentioned. Can you talk a little bit about the idea and the traits and principles behind HRO, or highly reliable organization? Some of our listeners might not know about that. How can you share more about that?
Absolutely. Basically, what happens, and I've learned from healthcare, and I've been in it 30 years. Is what, and this is probably more with hospitals than anything, is they like to have quick fixes. They like to create programs and do something. A new leader comes in and I want to do this and we're going to be the best. And what you learn about this world is it's not a quick fix. It's a culture and something you build over decades. And that's tough in healthcare because you have changes in leadership, you have changes in strategies and so on. But the HRO came up, there was a ton of research done where a lot of different researchers outside of healthcare studied organizations that were really, really high risk ones that could not afford to have, a mistake or problems like nuclear energy and aircrafts and so on. And they studied what their principles and, they kind of designed and wrote a lot of research on it from the 80s and 90s and the early 2000s. And then healthcare came in and kind of said, well, we want to be an HRO. They were labeled as high reliability organizations, but actually one of the key researchers that most of the people in healthcare know, she's moved on from University of Michigan to Johns Hopkins now, and she's gotten more involved in the healthcare arena. And now her terminology, even though she did this research 30 years ago, is we should be calling this organizing, high reliability organizing, and not an organization. There shouldn't be a destination that we try and seek in healthcare. It should be an ongoing process that we're always working on. And so I think that's kind of been my learning over time. There are tons of principles from different researchers, but there's really just some basic things that you do in whether you want to call it high reliability or not, or safe systems, or there's terms you can use, but to me, it doesn't really matter. It's the fact that you become excellent in this area of safety, and there's just ways you do it. So,
I mean, it's not a yes, no, highly reliable or not, any more than we could say an organization is lean or not. There's sort of a spectrum, or it's a bit of a cliche to talk about a journey, if you will.
That's exactly right. And I think what a lot of hospitals got stuck in is they would see other hospitals do this, and they would get trained by a vendor to be an HRO. And they say, well, we want to be an HRO. And then that would come up to their senior leaders, and they'd hire someone and say, that's what we're going to do. And that is really not what any of the research had. The research was not designed to develop HROs. It was designed to describe them. And so how you develop them is very different from just the description, in my opinion, of the principles that we use. But there are people, big organizations that have jumped onto this in the last 10 years. And that's kind of where hospitals go to. They tend to go to vendors for these programs that help them train and develop them. So,
yeah, I mean, yeah, I guess, yeah, it's tempting. Like if I couldn't just declare myself a marathon runner and go and run one tomorrow.
That's right.
There's a process that I guess I could go through to train and work my way up toward that. I would probably injure myself. I know I would injure myself if I tried to just go run a marathon tomorrow.
Right. And there's nothing wrong with saying we are going to continuously work to be more highly reliable, or to be high reliability organizing continuously, or we're going to work towards zero, and zero is a goal that we set, or a lot of them use zero harm as a term now, which I think is fine as a aspirational goal, because when you set these aspirational goals, you have to continuously drive to get there forever. And if you go to, like, I go to Alcoa's website, and zero harm is still on there from 30 years ago. So you can still have that, and that keeps you driving to get there. But I think the mistake we've made is we say, we're going to be an HRO, here's our principles, and here's what we do for 2 years, and it's all over. That's kind of, I think, what the miss has been. So
yeah. So like you said, it's not a project or a program. It comes back to culture, as you mentioned, culture already. I mean, can you talk more about some of the leadership components that go into creating a culture of high reliability, a culture of safety? What have you advocated for and tried to model in your leadership role?
Yeah, and this is, I think, from my own experience being in all the different types of hospitals with all kinds of leaders over the years, I have seen really good ones in safety, and I've seen ones who are good people, and they're maybe good CEOs, but they don't have the drive for safety the same. They might have it in some other area. But what I've learned is there is no way that you can really go toward this safety journey, or really wanting to be as safe as you can, without having the leader committed. No way. I mean, I've come to that realization. It's the number one thing. So the top leader has to be fully committed, because it comes down to lots of things. It comes down to transparency, how you're going to talk about yourself in public. It comes down to everything about, are we going to show other people our dirty laundry? Are we going to, when it comes down to, are we going to budget here compared to what we need for this equipment to protect our employees with? It's a big deal. And the accountability also is a huge thing that has to come from the senior leadership. So absolutely, if someone came to me and said, if you were going to do a safety program, what's your number one thing? I'd say you have to have a top leader that's fully committed. It still doesn't mean it's going to work with just that, but that is what you have to have, where, in my opinion, it doesn't work as well as you ever wanted to. So I think that's huge. Absolutely.
So are there other things what else would help demonstrate that full commitment? You mentioned already transparency, that willingness to I guess share the real reality of of not yet having perfect safety, but working toward it. What are some other ways a top leader shows that commitment over time?
Well, I think they basically get engaged with, so say that they're working in an operating system or a lean management system, or they are out in that, you call it the Gemba, whatever. They're out there every day. They're out there every day engaging with the front line, and they're connecting, and they're learning from that. And that's a huge thing that lean management people have done that for 30, 40 years in management. And it's a significant, and then you have leadership at different levels that have to be fully engaged. So it isn't just driven by the top leadership, but then the middle management people. And then the front line leaders have to be a big, and then healthcare, which is unique from other organizations. There's a huge component that can make or break a culture, and that's the physicians. So we have physicians. The other industries don't have physicians. We have physicians that are big leaders in our organizations. And I've told them for years, when I start my physician safety training talks, I say, my first slide is, you are a leader whether you want to be or not. So when you walk into that hospital, you are a leader. And people look at you, and people look at your modeling your behaviors. And people will wash their hands if you wash your hands. That kind of, it is a huge thing, how you set the tone in the operating room. So the physician piece is very, very unique that other high reliability or other non-healthcare organizations have not had to deal with. So there's components of leadership, I think, the different levels. And then also, I think the physicians are just a huge, huge piece. So.
Yeah. So maybe we can explore the idea of learning from other industries, because like you said, there are a lot of similarities, I think, in healthcare organizations, but like you said, the physician dynamic is different than, let's say, an airline. And there have been a lot of attempts for people in healthcare to learn from airlines. The pilots are an employee of the organization. The dynamic in healthcare where the physicians are often part of an independent group. They're not part of the direct leadership chain. That creates some challenges. But in that context, though, I guess my question is, how do you go about learning from other industries then, even with the differences that you point out?
Well, and that's a difficulty when you try and translate it into healthcare in a very kind of, I'd say, didactic or kind of stiff way. You have to adapt it, and you have to, but there are tactics that are used. There's team building tactics. There's, whether the pilot he tells everybody to call me by my first name, so you're more comfortable to speak up. Those are the same things we can do with physicians. So there's a lot of similarities in the trainings and the tactics that we would use that are very, preventing errors, how you approach a task and how you stop and check yourself. One of my biggest ones that, I look at healthcare, and sometimes healthcare doesn't seem to want to test the edges sometimes. So, for example, when I was at a construction site, I saw 800 people in their morning huddle coming out and stretch because that was their biggest issue. So I go to the ICU and say, your biggest injury with your nursing staff is moving patients. So you got to stretch in the morning. And they look at me like I'm a nut because that's not something they were taught in nursing school. And and then, another one is a huge injury we have is people in the wintertime in the north, people walking through through an icy walkway and breaking their ankle. Mm-hmm. And that's a real problem. So checking yourself, we have a Walk Like a Penguin program that we do everywhere. And I said, it's a huge success if people think a certain way and act a certain way and own their safety. So I think there's components of safety at the leadership level, but then there's also a huge component at the worker level where they have to own their safety as well. So, but yeah, and that's very much, I think, what's taught in the non-healthcare world. But I think the translation into healthcare is a challenge. It is a continuous challenge. The other thing that's added in healthcare that's very unique is we have patients. So when the scientists study human factors and all the environmental kind of safety issues, it's pretty much the worker and the tool or the machine, right? And in healthcare, we don't just have those two, we have patients in the middle. So then we have these constant communications and working, and then we have patients that come in with some issue, they create a whole new issue when they're in the hospital. And then we also have the issue where we only have one death at a time. So we don't have 250 at a time like a plane going down. We have one at a time, and somehow that doesn't seem to get the same reaction. So it doesn't, even though it's a tragedy. So there's a lot of differences when you translate it into healthcare, but you've got to deal with them and you got to understand the healthcare world. And I think that's part of the challenge. So.
Yeah. And one other thing I wanted to ask you about, I know you have gone and attended safety conferences outside of healthcare. I was wondering if you could talk a little bit about, why you've done that and what you've learned from that experience.
Yeah. I mean, my favorite thing is learning from others. If you can learn from other hospitals, that's wonderful. I've traveled to tons of hospitals. I think if you can learn from outside of hospitals wherever something is done well, it is great to learn from someone, a big part of safety that you just have to have in your DNA is shared learning. You've got to be willing to share all the time. There was a statement made years ago when I was in a collaborative with the children's hospitals from a person at, I think it was a Cleveland Clinic or Rainbow Children's, I think. And she said, in Ohio, we compete on talent and we compete on, staff and things, but we never compete on safety. And if you truly believe that and act that way, it's a huge benefit. So when I go to I go to the construction sites, I go to Lowe's. I went to one of our local hotels recently to see how they did their linen. What's the way they do it, because our EVS workers were hurting their shoulders picking up the linen bags. And if you go to I went to a nuclear power plant recently, and it's fascinating to watch what they do and how well they do it sometimes. The hard part is you see the stuff happen, and it's hard sometimes to translate it into healthcare. Sure. So, they're the ones who are really good at non-healthcare is they do observations all the time. They observe everything. And so they are way out ahead where they observe defects before they ever become problems. That's a harder thing to get in healthcare, because typically in healthcare, we're reactive people. We react to issues. We have an event or we have a trauma or something, we react to it. And so we're not as good at the kind of preventative piece. And that's probably another thing that attracted me to this. I love prevention. Preventative medicine or prevention is a huge passion of mine too. So,
yeah.
But
so you had mentioned Alcoa, and maybe we can delve into that a little bit along the lines of what you've learned from outside healthcare. The late Paul ONeill, who was, of course, CEO of Alcoa. He was founder of the firm Value Capture. I wonder if you could share a little bit about some of your exposure to Paul ONeill and what you learned from him.
He is, rest his soul, but he is my hero in safety. And I've watched him since I first learned about him and read about him. And I just read stuff about him over and over as much as I can, because there is no better example of a leader driving safety in an organization than him. So, and I think some of the fascinating pieces about not just his story about when he started in '87, I think it was, but it's also the fact that they had outcomes from it, and they had revenue outcomes, and they had injury outcomes, and it's still the same 30 years later. So I don't know if you can have a better example of safety. There are some folks like Bill O'Rourke, who worked for him in Moscow, and some of the other Alcoa people I've seen speak that are it's just wonderful when they can speak from not just experience, but from the fact that this is what we did in safety. This is how you do it. And I can tell you, if you do it this way, it works. And so, that kind of stuff, I love watching that, because it's the best. And if you see how they do it, you bring it back and you try and make it happen in healthcare. But just like I said about the construction site, it's hard to, another thing they did that was fascinating, they had 14 hours of safety training before anybody could start working. I go back to a hospital and they throw me out the door if I said, you got to have 14 hours of safety training. So, so other ones, take it at different levels. And I think the Alcoa piece is a fascinating story. And I have it in my slides all the time. And till the day I stop working, I'm going to talk about them, because they're an amazing example. So, and then even the stuff they did with Value Capture over the years and how they've done this to help organizations. And I think there was a statement from Paul ONeill, if I remember, from having one of my slides, where he started working with healthcare after he left the government, and said, this is the toughest part. This is the toughest group to work with in the safety world. But so. Yeah.
Well, and for the listeners, if you haven't heard every episode, we had a previous episode with Bill O'Rourke where he told his stories about working for Mr. ONeill, being sent to Russia, and what Bill described as basically having a playbook of following the example that he had seen set by Mr. ONeill when he had the opportunity to go run the Alcoa business in Russia. He said basically, he followed that playbook. And as you were saying, Tom, he said it worked.
Oh, yeah. And it works. And I think one of the difficulties with healthcare is you go into a hospital or a couple of hospitals that are not really big and they have margin revenue issues. And okay, if we're going to do it, and the way they did it in Moscow is they invested money into rebuilding everything and remaking everything so it was safe. So you do have to put, finances and money into it. That's why you got to be committed. And so I think that's, sometimes you run into that with healthcare. There's a kind of a sharing of, okay, I know we have safety over here, but we've got our margins over here, and which one's more important? So, and I'll never, you can talk to leaders and say, is safety important? And they'll always say it's important, but is it really at that level of importance? But yeah, the Moscow story is great. The other ones they tell, I mean, they're just amazing stories because they're like the best of the best. Mm-hmm. And so you look at them and say, okay, if I could even get a few of those pieces into healthcare, it'd be wonderful. I mean, just the fact that, if, every serious injury, he wanted to be called every 24 hours. I'm like, wow, that's pretty impressive. Mm-hmm. So, and that drives safety. That's really what happens is if you have that accountability set up and the leaders are fully committed, it will drive the safety work. There's no question in my mind. You will have less injuries. You'll have less deaths to your patients that are preventable. There's no question.
Yeah. So one other thing wanted to delve into is having this dual focus on employee harm and patient harm. That dual focus, and if you can talk a little bit about how you see that going hand in hand.
Well, that was a wake-up call for me. So like I said, in the safety world, you learn as you go along. And if you get stuck in one way of doing safety, you're not very good. That's all I'm going to say. You've got to evolve as it goes along. It's always changing and better ways to do it. And you've got to be reaching out to learn from other folks, like I said. So when I went to Denver about 8-9 years ago, we had a vice president of human resources, and I'll give you his name, Bill Anderson, wonderful, wonderful guy. And he came from the manufacturing world, and he was incredibly passionate about employee safety. And he told me, this is what we call the board-approved goal, meaning there was 10% of our bonus was set on the injury rates dropping that year. So when I came as the chief safety officer, and I was supposed to build their safety program, and he said, here's one of your goals, and there's a lot of money based. I said, okay, I'll do it. And then he said, these are OSHA recordables. And I went off and said, what are those? I didn't even know what they were. So when you come, that's another fault of I think of the healthcare world. When you look at our industries that do safety, AHRQ, the IHI, a lot of our big industries that everybody follows for safety training, they do patient safety. They don't do employee safety. And so my learning out of that was employees, because we're one of the highest causes of serious injuries to employees of any industry in the country. And they're basically like 4 or 5 different types. And it's like, why don't we do that? Because it's the same thing. So when you do a safety program, the tactics you use, the methods you use, the rounding, whatever, it is the same stuff for patient as it is for employee. And so one of my attractions at Trinity was they were incredibly committed to doing those two together from the top leadership. And so that's what's exciting. But to me, it's like, I have no idea why we didn't include employee safety in our safety work in the past in healthcare. That's a very short-sighted process. And there's still a lot of people in healthcare that just focus, and their name is Chief Patient Safety Officer or Patient Safety, and that's all they do. And they delegate the OSHA stuff over to the environment of care people. But it's a huge thing, because it was so obvious to me that whatever tactics you used, they're the same. If you stop and check yourself before you give a medication, it's the same behavior you use before you get out of your car when it's icy. It's the same stuff, So I never really understood when I look back why we didn't do them together. But I think that was one of our shortcomings in healthcare. Is that's kind of what I was taught, is we do patient safety. That was a big issue, and we never heard about the other thing. So,
yeah. Well, I think it's good that I appreciate you sharing those reflections when you talk about the need to evolve in approaches to safety. Thank you for sharing some of that personal awakening or evolution that you went through. And maybe as a final question, I was going to ask you to elaborate on you choosing to take this role at Trinity, and the opportunity and the leadership and the goals that you have here in this role as Chief Safety Officer?
Well, we'll just set aside the COVID-19 thing. So that's, been a bump in the road or an issue that has kind of diverted us to some other work. Actually, it's gotten me a little bit more engaged in some of the mental health safety or the resiliency piece, which I think will be a good learning and growing thing for me, because that's a big deal. The burnout pieces, all that stuff, that's very important stuff in the safety for employees as well. But what attracted me here was the senior leader was incredibly committed to the patient and we call colleague, but it's employee safety at that organization, and wanting to build that, not just by itself as a safety program, but also along with their lean management system. And I looked at that and I said, this is the future. These are two we're going to be together. And like I told you, I think before, when I went to that conference in January, it was all non-healthcare people, and they were all doing safety for 2 days. And I said, do you do lean daily management? And they said, we've been doing that for 30 years, man. So it means, and I'm looking at healthcare where we're like competing with new programs, and it's just kind of bizarre. So anyway, I think the opportunity is to build those together. The operating system is like the chassis. It's like what you build it on. It's everything there. And same thing Alcoa did. And then you put safety in as the driver. And that's what drives your culture, I think. So I think the opportunity that came up, and it was a huge system, obviously, with 92 hospitals in 22 states and stuff. So I think just the opportunity to be able to do something like that and to build it for that size of an institution for the country, or to at least help build it, was incredibly exciting. So that's kind of what pulled me in, and we're getting back right now after the COVID or para-COVID stuff. We'll be getting back to it. So that's the exciting part. We will have outcomes. Let me tell you, there's no question in my mind. I love outcomes. And when you put in the right stuff, just like the other folks do, and you do it the right way, you show the outcomes. And then the beauty is, okay, I have cut down hundreds of serious injuries to my employees. I've cut down hundreds of serious safety events that would have been preventable. I mean, serious harm. We're talking loss of limbs or deaths and things in patients. And when you know that part of what you could have built there with an institution to have those outcomes is a wonderful feeling. So.
Yeah. Well, good. So it's great to hear about those aims, and it'll be good to track your progress and everything that stands ahead. So, our guest again today, Dr. Tom Peterson, and as he alluded to, I'm sure it's quite intentional that you are the Chief Safety Officer. That's a broad title, not the Chief anything blank officer.
That's correct. It's a new, and they're pretty rare. There are not a lot of Chief Safety Officers overseeing, employee and patient safety in any hospital in the country that I know of. So it's a new position, just like the one in Denver was a new one. And that's the focus. And so I think that's another commitment from the organization. What you can see is they're committed to safety. They're going to build that, with hopefully the support and direction that I can help with. And they're willing to put the injuries on their incentive board things and everything. So I think it's a really well supported process. And part of it, when you see that title, just people should know, most places you go is Chief Clinical Officer, Chief Quality and Safety Officer, Chief Patient Safety. There's not a lot of just Chief Safety Officers anywhere. So it's unique. Yeah.
Yeah. Well, hopefully we'll see more of that. And again, Tom, thank you for sharing your thoughts and experiences and reflections with us today. Really appreciate it.
All right. Thank you very much, Mark. Thanks for having me.
Sure thing.